This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, this is Trey Bateman, currently between jobs, but will be beginning work at Virginia Commonwealth University in Richmond, Virginia next month. Today, I have the pleasure of interviewing Gregg, who is a cognitive neurologist at the Mayo Clinic in Jacksonville, Florida. Gregg is the senior author on a paper published online in Alzheimer's and Dementia on June 6, 2025, titled Diagnostic Performance of Plasma p-tau217 and A-beta 42 to 40 ratio biomarkers in the Outpatient Memory Clinic. Gregg, it's always a pleasure. Thanks for joining me today.
Thank you, Trey, for the invite. Always a pleasure talking with friends and colleagues.
Well, I'm really excited to talk about this paper today. Almost every talk I've given over the last 2 years, the main thing that people seem to want to hear more about are monoclonal antibodies for Alzheimer's disease and blood-based biomarkers. This study looked at consecutive patients evaluated at Mayo Clinic in Jacksonville, Florida, between March 2020 and July of 2024 in the Outpatient Memory Clinic. The main criteria for entry was getting CSF analysis for Alzheimer's disease biomarkers and folks who also had blood samples obtained within a year. Can you give us a brief overview of what prompted you to do this work and the main findings of the study?
The reality is your questions are my questions and I think are relevant to all of us who practice in this field right now. And so this is a really collaborative project. It involved patients that were assessed here on our campus in Jacksonville, Florida through our memory practice. And in this case, blood-based biomarkers and CSF biomarkers, which were measured by our colleagues at Mayo Clinic Laboratories in Rochester, Minnesota. What sets this study apart from those that come before it is really our focus, as much as is possible and practical, on engaging what I'll call a real-world patient population, or at least a real-world memory clinic population. And that's really what we did here. So to date, most of the studies in the literature, they consider performance of blood-based biomarkers in let's call it a pretty highly curated research cohort. I think, as you know, these cohorts are usually comprised of pretty healthy participants with early symptoms of Alzheimer's disease, often compared against a cohort of cognitively normal controls. I don't know about you, Trey, but that's not exactly reflective of my clinic population, which most often includes patients who have many other potential causes of dementia and, time to time, other health factors that might influence the performance of blood-based biomarkers.
Absolutely. I feel like a lot of the patients that show up to clinic are not well represented by some of the really clean cohorts that we see these biomarkers being studied in. And so it often leaves us with some external validity types of questions here.
Agreed. And so it's that question of generalizability that gave us the impetus to do this work. And what we accomplished here, well, we enrolled just over 500 patients. So these are patients who came for assessment. So they all had memory complaints. And as a part of their assessment, there was a clinical reason or indication to undergo a diagnostic lumbar puncture for their evaluation. Now, the most common reason, the most common indication for that was to measure Alzheimer's biomarkers. So patients with syndromes that we thought were due to Alzheimer's disease are overrepresented in this cohort. Another common reason, well, patients with a CSF flow dynamic problem, or who we might have been evaluating for possible inflammation or, more recently, measures of Lewy body disease in CSF as well. These patients, they were consented at the time of the lumbar puncture. They agreed to bank spinal fluid and blood, and they also allowed us to collect their clinical details, which is really what made this project possible. And all of the cases were evaluated by a neurologist, and then a secondary evaluation looking at the medical records by a panel of neurologists to come up with what we'll call a clinical diagnosis. What we did with these data, well, we then considered the association between plasma p-tau217 and clinical diagnoses of symptomatic Alzheimer's disease. And separately, we also looked at how closely did plasma p-tau217 levels map standard Alzheimer's biomarkers measured in CSF, really asking that question of how often did what we see in the blood match with what we saw in the spinal fluid, our gold standard test here in this study. We applied some thresholds. These are thresholds for biomarkers that were validated in that nice, clean research population, who in this case all had amyloid PET scans. And so we tend to know how the plasma p-tau levels should perform holding amyloid PET as our gold standard. This included use of a 2 cut point strategy that our lab uses. So by that we mean we use one threshold above which we'll call people positive and another threshold below which we'll call them negative, meaning there's a gray area, something in between. We refer to those people as intermediate or indeterminate testing, and that's really a population that probably needs some other tests to really truly determine what their amyloid level might be. What we ended up finding here, well, plasma p-tau217 levels, they were consistently elevated in patients who had clinical syndromes that we attributed to Alzheimer's disease. If we take out around the 15% of people who had those intermediate test results, so those are folks who are going to need other tests, well, of that remaining cohort with definitive results, 233 of 246 people who we thought had a clinical syndrome due to Alzheimer's disease had positive p-tau217 levels. So a sensitivity of 95% for detection of patients with a clinical diagnosis of symptomatic Alzheimer's disease. We also saw some positive blood test results in about 34 of 193 people who had clinical syndromes that were attributed to other things. Now, namely Lewy body disease or limbic predominant age-related TDP-43 encephalopathy, that syndrome we call late. And so that gives this test, at least compared to the clinical diagnosis, a specificity of 82%. And as I've already said, about 15% of people, they had that intermediate test results. Those are folks who we had to go on and do another test to really get a better idea about their amyloid status. Plasma p-tau217 results, they closely paralleled what we saw in CSF. So that was good news when we're referencing that to our gold standard measure, using established cutoffs for the CSF biomarker being p-tau181 divided by A-beta 42. So a p-tau181 A-beta ratio. We had concordant results, in fact, in 91% of patients. Plasma p-tau217 levels, they were positive in 93% of patients who had CSF biomarkers that suggested AD neuropathology. So that's a good result, certainly what we want to see. We also saw positive results in 5% of patients who had negative CSF biomarkers. So we might think about that as a false positive rate of 5% in this cohort. There was some slight improvement in biomarker performance when we added in plasma A-beta 42, creating this p-tau217 A-beta 42 ratio, which you probably know a bit about since it's been recently FDA approved for this purpose. And important to note that any measure that incorporated plasma p-tau217, whether standalone or with the A-beta 42 ratio, vastly outperformed A-beta 4240 as the blood-based biomarker in this clinical cohort.
One of the things that I was really interested to see in a real-world cohort was looking at the renal function. That's something that's come up in a few of these cohort studies that have looked at things that might impact how these biomarkers function in patients who have medical comorbidities. Can you tell us a little bit about how kidney function impacted the performance of the biomarkers?
A great point, and particularly important when we're trying to translate findings from a research cohort into a clinical cohort, is having representative populations. And we did have patients in this study who had various levels of kidney function. So we made sure to, as best as possible, measure creatinine in the blood at a time point as close as possible to blood sampling for these biomarker tests. And what we showed is that impaired kidney function, so we're talking about renal clearance, getting to that to moderate to severe level, and eGFR less than 45 milliliters per minute divided by body mass calculations there. But an eGFR less than 45 was associated with a higher potential for false positive serum test results. So I think this amyloid proteins being cleared from the brain into the blood. And if the kidneys aren't working well, it may not get out of the body normally. We might see it as elevated and could, in that situation, make a false determination of Alzheimer's disease. And so the practical learning point here is if you have a patient with kidney disease, as I did earlier this week, you can still order this test. If it's negative, that's helpful. It's a negative test. If it's positive, I'd be very cautious before interpreting that to suggest that there may be cerebral amyloidosis. A positive test in that patient population probably requires a more direct measure of cerebral amyloid, either amyloid PET or perhaps a diagnostic lumbar puncture.
I think that's a great point. It brings up something that we're going to shift to a little bit here, talking about some different cases, some real world experiences. And in part, I'm looking forward to getting your thoughts on some recent cases that I had. And I think that illustrative to hear how some subspecialty clinics are approaching this recently. In fact, when I first heard about the topic for this podcast, that very day I had seen a patient who had been referred for evaluation due to, quote, memory concerns with a positive p-tau217 that had been obtained by their PCP. It was an 82-year-old retired college professor who had basically come in and said, I'm getting worried about memory loss, have a family history of some dementia in one of his parents. And so he'd heard about this new Alzheimer's blood test. And with really very little else done, the p-tau217 was ordered and it was positive. And so this person had to wait somewhere between 6 to 9 months, which is a pretty typical wait for a lot of subspecialty memory clinics to get in to be seen. And once I saw him, his neurobehavioral status exam was really entirely normal. There was no objective evidence of impaired cognition. And it turns out that his worry about memory was really just that. He was worried about having memory decline in the future, but didn't even feel like he had any subjective decline beyond his friends and colleagues his age. So have you seen patients like this, and how might this paper impact how you think through a case like that?
Is a great cautionary tale as you're telling it. When we have good tests, particularly sensitive tests, they're going to find the pathology of it as if it exists. And I think that's what we're seeing. That's what we see in your case here, and seems to be what's suggested by our paper as well. We have elevated plasma p-tau levels in patients who have other syndromes, because patients with other syndromes can have Alzheimer's disease changes. And as we both appreciate, one of the biggest risk factors for Alzheimer changes is age. So in individuals who are getting up there in age, above 75, certainly above 80, we would expect, at least referencing autopsy studies, that between 30 to 40% of patients are going to have Alzheimer changes. Doesn't mean they're going to have symptoms, as I think your case illustrates, and it doesn't mean that they can't have something else that might be causing this problem. So when it comes to these patients who we can characterize, let's call them worried well, for lack of a better word, I think it's not appropriate, at least not right now, to be using plasma p-tau tests just to screen to determine potential risk of Alzheimer's disease, because it can really only increase worry in some of these cases. That opinion probably going to change if we have other approaches or treatments that we're going to use with the idea of preventing symptomatic onset in at-risk patients. So let's leave the door open to that. But right now in clinical practice, I don't recommend doing this sensitive test in my cognitively normal patients, for the reason that we may get some elevated results that don't relate to their clinical care, aren't going to change the management. And there's another factor here. If we're thinking about what are the populations these tests are validated in, they're validated in symptomatic patients. And so a negative test result, while we might take that as reassuring, well, do we really know that a negative blood test in that patient means they don't have Alzheimer's changes in the brain? We haven't validated or set the thresholds according to that patient population yet.
Yeah, I think that's exactly right. And even the latest staging criteria from the Alzheimer's Association group, they pointed out that while one can diagnose an asymptomatic population, at least in clinical practice, one really should not do that. So I think that one of the things that really worries me, the widespread frictionless ability to get these tests, is that people kind of jump past the first and perhaps most important feature right now, which is you got to define the clinical syndrome first before you worry about etiology.
And we got to have an idea what we're going to do with the test result when it comes back, another common problem. And for the reasons you've said, if you've got a wait time of 6 to 9 months in your clinic, simply having my answer be if it's positive, I'm going to refer to Dr. Bateman is not a good clinical strategy to put into practice. You're picking my brain on a case, so let me pick your brain on a case. I'm actually going to match your case with another very similar one. This is a patient that I saw very recently, more or less the same age as your patient. Let's say that this gentleman's 84 and coming in for a similar reason, amnestic predominant complaints. But in this case, there's some clear problems. So it's not worried well. These issues were initially subtle, but over the last 2 to 3 years, his very reliable spouse tells me they've become increasingly obvious, and to the point that he's now making mistakes with his medicines. She's helping with that and repeating himself frequently in conversation. This is evident to me in the clinical office as well. So this guy, he has deficits. They're definitely new. They're definitely different from before, and they're progressive, and they're starting to interfere with some of his daily function and daily aspects. And so I saw him at this point and pretty much thought this is a early symptom of a dementing process. We could debate whether he's mild cognitive impairment or very mild dementia. I think probably the best label for him here. And I even went as far in that visit to communicate my concern and suspicion that Alzheimer's disease might be the cause. So here's a patient where I'm going to order structural imaging, as we always do, MRI in this case. I added TSH and B12, and the question became, should I be doing plasma p-tau217 in his case? What are your thoughts on that?
Essentially just gave us the textbook description of a patient with late onset Alzheimer's disease, right?
That's really what I'm trying to do, and that's what I thought. Here's maybe the mistake I made then. I ordered plasma p-tau217 in blood along with kidney function. And in this symptomatic patient, I'm going to argue I think it's appropriate here because I've got an idea on how I'm going to interpret these tests. But here's what I didn't expect. His test was negative. So a good blood test for markers of Alzheimer's disease, not finding markers of Alzheimer's disease in this gentleman. The big question, of course, that they ask me and that I've got to be prepared to answer is, what do we do here? Well, I'm going to say that in this age group, I think a negative test may, if anything, be more helpful than a positive one, because unlike in your patient where a positive test doesn't mean it's causing symptoms, a negative test here, I think, really does make Alzheimer's disease a whole lot less likely. And getting back to some of the findings in the paper we're discussing today, getting back to other common causes of late onset amnestic predominant syndromes, in this case, I think the negative test helped me to move along the differential diagnosis. And when I put it with the findings from his MRI, so no strokes, some small vessel changes, no hemorrhages, but a lot of hippocampal and temporal atrophy, in this situation, I think this test really helped me with confidence tell this patient that I suspect he has the limbic predominant age-related TDP-43 encephalopathy. And even using the terms probable late, according to some of the new clinical criteria here, seemed appropriate.
This is the kind of thing that's going to start popping up in clinical practice that's always been there, but for the most part, prior to the widespread introduction of these etiologic biomarkers, we'd have just called this person Alzheimer's disease in many instances and kind of moved on. And I think that a huge take-home is to be prepared for what the biomarker means when it's either negative or positive. And this is a great case because it demonstrates that negative biomarker actually really helps you get a diagnosis, but it's one that a lot of folks may not have heard much about, right? This limbic predominant age-related TDP-43 encephalopathy we're seeing it. We've been seeing it for a while, but it's something that I think a lot of people are going to have to start getting more familiar with because they're going to see these Alzheimer's-like patients, and then the p-tau217 is going to be negative.
Well, and where I really think the biomarker helped this patient was, of course, he was seeing me with the idea, does he need treatment with new monoclonal antibodies against amyloid? And I think I felt pretty comfortable in this situation knowing the performance of this test in our clinical cohort and saying that no, he would not be a good candidate for this treatment. And so I'll argue that in his case, I think the blood test, appropriately ordered and interpreted, spares him a more expensive amyloid PET scan or perhaps a more invasive diagnostic lumbar puncture for Alzheimer's biomarkers.
Yeah, absolutely. I would agree entirely. As I mentioned earlier, and it keeps coming up as a major factor here, and it's something that I think that your paper highlighted so well because it clearly separated out there was a clinical diagnosis or a syndromic diagnosis. So when we're talking about this primary amnestic dementia syndrome, that's really just a description of the etiology. And I think that being able to diagnose one before moving on to the other is really important. So another case I'm going to throw at you that I think maybe helps to solidify that point. A few months back, I saw a 78-year-old woman who came in, 4 out of 4 criteria for dementia with Lewy bodies. She had a dysexecutive cognitive profile, REM sleep behavior disorder, was having well-formed visual hallucinations, and was even mildly Parkinsonian. So there was nothing about this case that said Alzheimer's disease to me, but the referring clinician had gotten a p-tau that was positive. And so the referral to me was for, well, what does she have DLB? Does she have Alzheimer's disease? What's causing her symptoms? So we ended up getting an alpha-synuclein skin biopsy just to really nail the diagnosis down and to really clarify it. And so here you've got 2 biomarkers that are positive. So what do you tell this patient?
Well, I think this is another illustrative case of how do we interpret these biomarker results. And this patient and many others like her were well represented in this research study as well. And that's what we saw. Lewy body disease patients or patients with a syndromic diagnosis of dementia with Lewy bodies, a lot of those individuals also had positive p-tau values, elevated p-tau values. Now, I think we both appreciate why that is. We know from autopsy studies that maybe as high as 40% of patients with dementia with Lewy bodies have comorbid or concurrent Alzheimer's disease changes. And it's a great case because it emphasizes the importance of knowing the strengths and the limitations of the tests that we order. These biomarkers, we think, measure specific aspects of specific diseases. So we hope that plasma p-tau217 is going to be really specific for Alzheimer's disease. If the disease is present, therefore, we want the test to be positive. If it's negative or if the disease is absent, we want the test to be negative. But we still need to think about this. And you're a good example here that good biomarkers don't replace good clinicians. I do think, though, that good biomarkers can make good clinicians great clinicians. And so recognizing what that might mean for your patient, well, maybe comorbid Alzheimer's disease might have some contribution to her rate of decline. Maybe it'll predict response to other medications. I think we can garner some information from that, but we need a lot more work to understand what does that actually mean in this context. But I think the diagnosis is the clinical diagnosis here. Dementia with Lewy bodies, Lewy body pathology, and I'd be guessing that at autopsy, we'd also see some Alzheimer's disease changes here.
Exactly. The conclusion that I came to, I think that one of the things that I hear people say when they're presented with a case like this is that, oh, well, see, p-tau217 didn't really do what it was supposed to do, right? It was positive in this other diagnosis, but I think it's really important to remember what the biomarkers are measuring. All they're measuring is if you could take a brain out and look at it under a microscope at that cross-section of time, would you likely find, in this case, AD neuropathologic change? And very likely you would. Ping did an excellent job here. There probably is AD neuropathologic change present. It's just we have to know that doesn't mean that should overrule the clinical diagnosis of DLB in this case.
Just the critical importance of interpreting a test result in the context of the broader clinical picture.
Yeah, exactly. So I told you there were two things that people kept asking me about. So I'm going to bring up the other one now because I think it intersects nicely with this, and that's monoclonal antibodies in the context of these blood-based biomarkers. So especially with the FDA approval of the p-tau217 to A-beta ratio, is whether a blood-based biomarker is good enough for confirmation of AD neuropathology, specifically for inclusion in treatment with monoclonal antibodies. I think some places are maybe starting to rely on them in some cases. Others are insisting on a confirmation with CSF or PET. So, Gregg, what guidance do you think we can get from this study, and what's the current practice there about how to handle that question?
If we take a 1,000-foot view on blood-based biomarkers here, and particularly plasma p-tau217, I think we should conclude these are good biomarkers. They're a substantial improvement, an advance, a step forward, whatever we want to call them, over the first-generation biomarkers. Let's call that plasma A-beta 42 and 40 ratios, plasma p-tau 181. I think they're even superior to other interesting ones like GFAP and NFL. But the question you're really asking is, are they good enough? And I think that question probably has to be addressed on a patient-by-patient basis. So at this point, I'm not going to say I have a rule that I'm going to follow here when it comes to these biomarkers. The cases we've discussed, I think they do a good job of highlighting how positive or negative tests could be helpful, but potentially harmful if all we're doing is making a decision based off a case. Your Lewy body case, if we weren't going to be thoughtful in our clinical approach, we might try to argue that patient has Alzheimer's disease and therefore should receive antibodies against amyloid. I don't think that's the right approach right now. Or your first case, the 82-year-old who really doesn't have any recognizable clinical syndrome, who I think could probably only be harmed by exposure to anti-amyloid therapies at this point with no clear efficacy or potential for benefit. And so this just emphasizes that need to reflect on pretest probability when we're interpreting these test results. There have been some good papers even featured on the podcast about pretest probability and utilizing that in our clinical decision making. And I think what some of those papers suggest when it comes down to blood-based biomarkers, p-tau217 in particular, it's going to have the greatest value in younger patients who have a low likelihood of comorbid amyloid pathology and who have pretty clear AD syndrome. So be that amnestic predominant mild cognitive impairment or early mild dementia. I think it's also pretty helpful in older patients when it's negative, as like the case that I highlighted showed, and so can help us steer away from treatment in those cases. But in all other situations, we're still going to need some of these gold standard biomarker tests when we're trying to make a decision that comes with substantial risk, substantial cost, and ultimately results in invasive medications. And so in my practice, I'm using this as a good screening tool for symptomatic patients. But at least right now, I'm still doing a lot of confirmatory testing before moving forward with. Our data from our own cohort has caused me to stop and question that. I think there's a subset of patients who we probably would be safe making a decision based on blood tests alone. But of course, we want to see that validated at other sites and learn from the experience of other providers.
I couldn't agree more. That's sort of where I've landed right now, in that If I had a patient that every piece of the data was really pointing towards A as the causal reason for the clinical syndrome, then I think the patients exist for whom I would accept the blood-based biomarkers alone. So far, I've not had that case since the FDA approval, but I could foresee it happening. So I think that, I think remembering the pretest probability and the questions that we're trying to answer about etiology is just always important for us to keep in mind. And this paper certainly helps us think through that. So in the few seconds that we have left, could you summarize for me the key take-home message that you really want listeners to remember about this work?
Yes, these blood-based biomarkers that incorporate plasma p-tau217, the key point is they have a role in clinical practice. When they're correctly applied by good clinicians and taking into account data that's available to us, so that includes demographics, data from the clinical history exam, and other testing, these blood-based biomarkers are potentially non-invasive, much more accessible tests that I think we can apply to streamline diagnostic assessment. And in reality, they seem to have the potential to improve care in our memory clinics and maybe even outside of that in research settings. So looking forward to next steps as we learn more about how to apply these well in real-life populations.
Thank you so much, Gregg, for sharing your findings with us, and thanks for taking the time to discuss this important paper. I've been speaking with Gregg Day, senior author on the paper titled Diagnostic Performance of Plasma p-tau217 and amyloid beta 42/40 ratio biomarkers in the Outpatient Memory Clinic, which I would encourage everyone to read in Alzheimer's and Dementia.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.